In this chapter, we'll be discussing the digestive system. If you had a burger for dinner, your body is not going to be able to take the parts of the burger, the bun and the meat and the condiments, and turn it into something it needs. It's first got to actually break it down. It's going to do so by grinding it up with your teeth, the roof of your mouth, the ridges on your hard palate. It's going to break it up chemically with acids and enzymes. You're going to absorb what you need in the form of amino acids and fatty acids and carbohydrates, such as simple sugars. And then you're going to eliminate the rest. So the waste will have to be gotten rid of. This is going to happen in basically a tube that's about 30 to 40 feet long. You'll see some variation in measurements simply because it's much longer in a deceased individual than it is in a living individual because of normal resting muscular tone. This is sometimes referred to as the gastrointestinal tract, or also the alimentary canal, or sometimes simply the GI tract. Here's a list in pretty much order of what happens when you eat something. Ingestion refers to putting it in your mouth. Mastication refers to chewing it. Deglutition refers to swallowing it. Digestion refers to breaking it down. Secretion refers to the amount of fluid you're going to be putting into the food content. That's going to start with saliva. You're going to have some mucus added in. You're going to have, again, stomach acid, all these enzymes. You're going to have bile added in. You're going to end up putting liters of fluids into your GI tract to make the absorption possible. Absorption is when you're going to be bringing in substances that your body wants to keep. And then defecation will be elimination of the solid waste. Here are a few just random facts that I wanted to remind you of. First off, the esophagus is going to be passing through the mediastinal cavity. Remember again, mediastinal, middle of the thoracic cavity. Is most of the digestive organs are going to be within the peritoneal cavity. There are portions such as, for example, the distal end of the large intestine is going to be retroperitoneal. And then, of course, the esophagus, as it passes through the thoracic cavity, is going to be not considered within the peritoneal cavity. The organs will be covered with visceral peritoneum. Remember the serous membrane we've talked about. And then the abdominal pelvic cavity itself is going to be lined with parietal peritoneum. You're constantly filtering out fluid from your plasma and putting it into your abdominal cavity, about 7 liters per day all total, but you're also constantly reabsorbing that. So this is going to provide lubrication so the organs can slide across each other, and it's also going to help prevent adhesions. The mesenteric membrane may be something you haven't thought about before, but this is simply an extension of that peritoneal membrane. So this is actually a double sheet of it, and it's going to help suspend part of the GI tract. It prevents things from getting tangled. So I always talk about in class, if you were to take a very soft, very flexible tubing and put it into a bucket and shake it around for 80 years, chances are high you can end up with a knot. But if you take that same tubing and sew it onto an edge of a sheet and then pile it into the bucket, there's really not a very easy way for it to become entangled. And now there are problems that can happen with it. You can have tears in it that will entrap pieces of intestine, etc. But for the most part, it comes in pretty handy. You can think of this as kind of an emergency band-aid in circumstances. There'll be times that people will present to an emergency room with a perforating wound into the abdomen, and the mesentery will actually be hanging out. It kind of plugs the hole. Same thing if you have leakage in your intestinal tract. You'll find sometimes the mesentery will try to seal that off. So the dorsal mesenteric membrane is going to make up a large pouch that's referred to as a greater omentum. So the word omentum means apron, so that kind of gives you a visual. The ventral mesenteric membrane is present in the fetus, but through the rotation and etc., this is going to become what's known as a falciform ligament, which is going to attach to the liver and stabilize that under the diaphragm. As you can see here, the mesentery is sort of a lacy tie. I describe it as lacy anyway. There's a lot of fat in there, so people who carry a lot of abdominal fat, that's where they're storing it. It's going to be inside the lineage of the mesenteric membrane. Here's another photo showing the mesentery, and you can see with this, it's going to be stabilizing the organs in position. You're also going to have some lymphatic material located there. In these next few slides, we'll be discussing the layers of the digestive tract. This gives you a pretty good diagram here. What you're looking at here, this is the mesentery, as it's going to be suspending the intestine, basically. And if we look at it from the inside out, your mucosa is going to be located right here, and we'll discuss the individual layers of that. Then, of course, under the mucosa, you're going to have the submucosa, and then under that, you're going to have a smooth muscle layer known as the muscularis externa. And the muscularis externa is going to be located right here. It's referred to as the muscularis externa because you have another smooth muscle layer that's actually part of the mucosal layer. This thinner layer is referred to as the muscularis mucosa. And then finally we have the serosa, and you will notice that this is going to be pretty much the same thing as the visceral peritoneum. So we're going to start on the innermost layer, and again, to orient you, this is going to be the part that's going to be in contact with what's left of the food that you ingested. And some things that you'll find here, you'll find some lymphatic tissue. Remember we talked about malt, mucosa-associated lymphoid tissue. You're going to have some goblet cells. You can actually see the little clear spaces right there on the edge. And anytime you see a goblet cell, you know there's going to be mucus production. In the small intestine, you're going to have cells known as enteroendocrine cells. And then there's also, again, that smooth muscle layer that I mentioned, referred to as the muscularis mucosae. So the smooth muscle layers, both this one and the muscularis externa, is actually 2 layers each. Again, it's smooth muscle, and you've got one layer that will be longitudinal. It'll run the length of the intestine or the GI tract, and then you'll have another layer that's going to be a circular layer. So the lining of the GI tract is going to be either simple or stratified epithelium. It's going to be stratified in areas where you need protection, such as the mouth, and then the lower part of the GI tract around the rectum. And it's going to be simple where you need a lot of absorption. So you're going to find a lot of simple epithelium in the small intestine. These cells are going to regenerate every few days, and this is a protective mechanism because, again, this mucosa is going to be in direct contact with the stuff that you've eaten, and there's going to be, of course, some potentially toxic stuff in the items that we eat. So for that reason, these cells will go ahead and replicate themselves. But this is also one of the reasons that you'll find a fair amount of GI cancers when you start looking at, for example, colon cancer, etc. Remember, the more a cell replicates itself, the more it divides, the more chances you have of DNA misinterpretation, and that could potentially be an oncogene, which is going to end up with causing cancer. Going deeper through the mucosa, you'll enter the submucosa. This is going to be dense irregular connective tissue, and it's going to be home for some blood vessels, lymphatic vessels, may have some exocrine glands, which will depend on which part of the GI tract you're in. And it's also going to be the location for a network of neurons. This is going to be known as the submucosal plexus, and another term for that, used by some references, is Meissner's plexus. This is mostly sensory neurons, and they're going to be picking up information about intestinal contents and stretch, and helping regulate the activity based on what's there. This is part of your autonomic nervous system, which means that you're not going to be aware of what's happening here. It simply is going to be keeping the information local and helping stimulate digestive activities based on its input. The muscularis externa, that's the name used by most references. Sometimes you'll see it simply referred to as muscularis, but that's potentially, to me, confusing. So again, this is going to be a larger layer of smooth muscle, and it is double, again, just like the muscularis mucosa. And this has the job of pushing food down the GI tract, and also it's going to be helping mechanically break it up. So this is going to contain another network of nerves, and I see that this lovely app has cut off my slide here, and this app is known as the myenteric plexus. So you may recognize the term myo as meaning muscle, and that's what they're referring to. So this is going to be the network of neurons that's going to control the muscular activity. The epithelial layer known as the serosa is again the same thing as the visceral peritoneum, that is your serous membrane. There are a few places on the GI tract that is not included with serosa, and that's going to be the esophagus and then the lower rectum. The tissue there that surrounds those is referred to as adventitia. It's just more of a loose, frothy connective tissue. So we've talked about the muscular layers, and we talked about the muscularis mucosae, and we've talked about the muscularis externa. So what does all the smooth muscle do? It basically has a couple of different jobs. One is mixing, and one is moving the ingesta on down through the intestinal tract. So peristalsis is a progressive motion, and segmentation is a mixing motion. To get a visual of what this would look like, imagine taking a long knee sock and cutting the toe off one end, put a tennis ball in, and then hand over hand keep squeezing that sock until you push the ball out the other end. That would be an example of peristalsis. With segmentation, you could put the ball inside the sock, put one hand on each side of the ball, and just squeeze it back and forth. So you're moving the ball back and forth, but it's really not making any progressive motion. So, and by the way, I wanted to show you this term right here, borborygmus. You will see it sometimes referred to as borborygmi, which is plural. And that's simply the gut sounds that will be produced by this motion. So you've all had your stomach kind of growl when you're in a quiet place and you really don't want it to happen. But it happens to everybody. And what's even more important are the sounds that you don't hear. You should hear, when you listen to an abdomen with a stethoscope, but some sort of borborygmi going on at all times. So if you don't, then it's indicative of a problem. If you've ever had surgery in a hospital where you've undergone general anesthesia, you will notice one of the things that they will do is listen to your abdomen as you're recovering. I don't have any test questions or homework questions about this, but I did want to mention it. There's something called a migrating motor complex. This is a progressive motility that is not related to food consumption. So whereas peristalsis is going to kick in and be triggered when you eat, this MMC is happening all the time. And what it does is going to be continually producing these low-level motions to try to keep the bacteria in your gut from going upward where it would be devastating. So you do have bacteria in your large intestine, and you've got to keep that from going into your small intestine, so that's going to help. So let's talk about what controls the digestive system activity. And first off, we're going to look at the autonomic nervous system. So this is sort of an overall central control. And if you look at the parasympathetic side, it's going to be happening when you're nice and relaxed, and it's going to stimulate digestive processes. The sympathetic is going to be your fight, fright, and flight, and that's going to inhibit digestion. It's going to actually send blood flow away from the GI tract. So if you're really frightened, really stressed, really scared, you probably have experienced a butterfly sensation in your stomach. You're not hungry. You might get nauseous. If you get fearful enough, you might evacuate your bowels. So parasympathetic, you have to be nice and relaxed. You're sitting there watching TV, and you're not really thinking about anything that causes stress. And they know this, and they give you the commercials showing you the hot, bubbling, cheesy pizzas, and it will make you hungry. So the parasympathetic control of the digestion is about the only time the parasympathetic system is stimulating something. Most of the time, remember, the sympathetic side is the stimulatory system. Along with central control of digestion, you've got a local control of digestion. So they talk about short versus long reflexes, and this is very simple. Short reflexes don't ever leave the digestive tract. We talked about the myenteric plexus, for example. So impulses for that can be entirely contained within the enteric system. So long reflexes will actually involve the central nervous system. So there will be some impulses and some directions coming from the brain and the spinal cord. So again, that's two neurologic methods. Now, you have some chemical methods, and we'll be talking about some hormones as we go through here. Most of these are peptide hormones. I put down here 18. They're coming up with new ones every year. A lot of these are produced by the enteroendocrine cells, which are located in the lining of the small intestine, especially in the duodenum. So we'll be talking about some of those individually. And then you also have some paracrine hormones. Those will be acting locally. In other words, they're secreted by one cell, and they're going to have an effect on cells that surround them. These are things like prostaglandins and histamine. So let's start talking about the digestive system, and we're going to work our way from the top down. Again, your GI tract is simply a tube. If you eat something, it's really not in your body, it's simply in that tube. It's not in your body until you absorb what you need out of that. So your mouth has the job of sensory analysis, both taste and temperature. It's going to also help regulate the size of what you swallow. We'll be talking a little bit about things like the arches in the back and the uvula, and those are designed to keep you from swallowing something so big it might choke you. So that's really the origin of the gag reflex. So you also have the job of mechanical breakdown. You can be grinding things up with your teeth. You have ridges on the top of your mouth from some mucosa that's overlaying your hard palate. You're going to be moving this around with your tongue and helping grind this food up. You also have some chemical digestion going on here. And in fact, classic test question, your very first carbohydrate digestion happens here with salivary amylase. There is a little bit of lipase here, but it's not really talked about as much. And then another big function here is going to be the introduction of saliva into your food. And we're going to talk about formation of the bolus, because that's what we're going to call it. You're going to be grinding up that food. You're going to be injecting liquid into it in form of saliva. And you're going to be using your tongue, your cheeks, and your roof of your mouth to shape it into kind of an oblong substance. So you can simply swallow it and it can progress down your esophagus. The mouth is going to be lined by mucosa, which is stratified squamous epithelium. Remember, that's the flat, irregular cells that are stacked up because you need protection here from friction. The underside of the tongue is thinner, and that is actually sometimes used for a site to put medications because you have a fairly quick absorption. It's pretty helpful. In fact, I'm sure you have seen now they've made over-the-counter antihistamines and that sort of thing. You can simply put in your mouth and dissolve little strips of a cellophane-looking type thing. But a lot of times you can squirt a liquid under the tongue and it'll be very quickly absorbed. So the labia are your lips. The vestibule will be between the lips and the teeth. The gingiva are the gums. The glossa is the tongue. And the bucca are the cheeks. So you should be pretty familiar with those. Like the lips, you're going to have receptors on the tongue for temperature. The last thing you want to do is have some really hot soup, damage your mucosa. You also have taste buds here. We talked about those, or we will talk about those in special senses. And mechanical processing, again, your tongue is going to give you the ability to manipulate the bolus, to move it around for better shaping and for better mechanical digestion. The salivary glands are paired in 3 different pairs, and I'm not going to be asking which set does what, but you will see that they have a difference in the quantity and quality of saliva they produce. The product glands are the big ones you see right here, and these will be the source of the salivary amylase. These produce about a quarter of the saliva. The saliva that's produced there is a little bit more watery. The sublingual, as you would suspect, below the tongue, and these will be a little bit more of a mucus production. You've got a little bit of a pH change there. Submandibular, again, you can kind of figure out those would be under the jawline. So these actually produce both mucus and serous secretions, and these produce the bulk of your saliva. You produce up to about 1.5 liters of saliva a day, so that's a pretty good amount of fluid. You swallow the bulk of that. Basically, if we were to lose all the fluid that we secrete into the digestive tract without being able to resorb it, we would be dehydrated very quickly. So one of the jobs of saliva is going to dilute anything that's toxic that you eat. There is a saying that will kind of hold true for just about everything in anatomy and physiology, and that is the solution to pollution is dilution. And so you may have had, for example, food poisoning before, and it's a pretty miserable feeling. You're going to throw up. What's one of the first things you do? Your mouth thirsts to water, and you're getting ready to kind of heave to eject the toxic stuff out of your body. So the solution to pollution is dilution, and that's one of the reasons that when you have any sort of GI upset, you're normally losing fluid from both ends. The body is putting more fluid than normal in there to try to flush everything out. My mother was always driving me crazy when my kids were little. Anytime they would have a stomach virus or any kind of, they're throwing up, diarrhea, this sort of thing, she'd always say, oh, give them some Imodium. I'm like, no. She was convinced that my kids would die before they were able to leave the house, but they survived. But the problem with things like Imodium is it induces an ileus, which means that it's going to reduce the amount of motility in your GI tract. And sometimes there is actually a good reason for that motility. You're actually trying to get something bad out of your body. And so if you take Imodium or something like that, you're going to keep whatever it is that your body really wanted to get rid of. And you can actually cause a bacterial overgrowth, and you can actually make it much worse. So the only time I'd consider using Imodium is if, I were perhaps getting ready to get on an airplane or something and I was in dire straits. So let's take a look at the teeth. And the dentin is going to be a very, very hard substance that's located here. It's pretty similar to bone, actually. It's going to be covered by enamel, which is what you see there in some shade of yellow, white, or gray. And a lot of that has to do with more genetics than dental hygiene in some cases. The pulp cavity is what you see, the deep part right here. And there you're going to find some blood vessels and nerves that come up through the apical foramen that is in the root. So when you have a root canal, what they're doing is they'll scrape all this out, and they will pack this area here with some sort of non-reactive material. There have actually been cases of dentists a couple of times that I've seen in the press, probably happens more than we know, that were arrested for using things like pieces of paper clips to jam down in there to seal up that root. So the root is pretty simple. It's going to be everything that's below the gum surface, and then the crown is going to be everything that's out of the gum surface. Let's talk about the pharynx and the larynx. I'll be sure not to confuse the two. The pharynx is used by both the digestive system and the respiratory system. So they divide the pharynx into 3 areas, and what we're talking about is this area right here. And so the top part that comes out of the nasal passage is going to be the nasopharynx. Then the part behind the mouth is the oropharynx, and then it moves into the laryngopharynx. So what happens, you can see here is your esophagus, and then here is your trachea. So there's a glottis, there's the epiglottis right there that's going to close off that glottis to keep things from going down into that esophagus. You saw the same picture when we discussed the respiratory center. Let's look at it now in terms of the digestive system. So when you eat, first off, let's localize. Here is your trachea, so there's your windpipe, and your esophagus is actually behind. So when you're eating and you're manually manipulating this bolus of food, it's going to end up passing under the uvula, and it's going to pass into your esophagus in that direction. So your epiglottis is going to fold that down and prevent it from entering the trachea. There's actually a couple of different stages of swallowing. The first phase is actually the only phase that's going to be voluntary. You're using your tongue and your cheeks to help push this bolus of food around. You're shaping it. You're going to be grinding it up. And what's going to happen toward the end of this phase, your tongue is going to move the bolus of food that you formed up and back into the pharynx. In this pharyngeal phase, what's going to happen is the bolus will pass through the paladopharyngeal arches if it's small enough. If not, you're going to keep on chewing. And once it hits the pharynx, it's going to become an involuntary phase. And then it moves into the esophageal phase, which is also involuntary, and peristalsis will take over and propel the bolus of food onto the stomach. The esophagus itself is not that exciting, but it's obviously a pretty important thing here. It's simply going to be muscular tube that produces only mucus. It's still stratified, but there's not going to be any keratin in this epithelium. This is a part that we talked about earlier. It does not have a serosa. It's actually going to be surrounded by adventitia. The type of muscle that you'll see in there, it will start out skeletal, and by the time it gets to the abdomen, to the stomach, is going to be a smooth muscle. And once again, like I said on the previous slide, once a bolus of food hits your esophagus, it's going to be moved to your stomach by peristalsis. So even if you swallowed something standing on your head, it's still going to be propelled toward the stomach. A sphincter is simply a circular structure. You can think of it as a valve, and there's really two types. It can be a physiological sphincter, which simply means it's not really a structure on its own. It simply functions like one. And then you can have a true anatomic sphincter where you actually have flaps of a valve. So the sphincter where the esophagus dumps into the stomach is known as the gastroesophageal sphincter. It is a physiologic sphincter, simply means that it's going to be functioning by way of contracting muscle. It's not a true flap or anything. And I'm sure you're familiar with a GERD, which is known as gastroesophageal reflux disease. This is basically severe indigestion. And what's happening is you've got stomach acid that is moving backwards up into the esophagus. It can be pretty severe. It can actually lead into Barrett's esophagus, which is quite often potentially precancerous. So it's not something to be ignored. So traditionally what they would do is actually go in there and surgically remove the stomach that had the receptors that caused the production of acid. That whole line of surgery got laid by the wayside with the advent of proton pump inhibitors. Remember, a proton is simply going to be, if I can get my stylus to cooperate here, a hydrogen ion. So that's a proton. So when you block production of the hydrogen ions, or the protons, that's blocking the acid production. So the problem is so many people are on these things such as Prilosec. They've actually shown that people who take Prilosec on a daily basis have an increased incidence of coming down with all sorts of things. Well, a big one would be C. diff, Clostridium difficile, which is a really, really nasty diarrheal disease. And when you think about it, your stomach acid is one of your nonspecific defense systems, and if you lower that, you've removed a barrier to infectious organisms coming in on your food. So it's now also associated with other things such as dementia and deafness, etc. But it is a very, very commonly taken medication. So if the esophagus ruptures, you're going to have a really nasty, probably fatal mediastinitis, because you're going to, again, you think what was located in that mediastinum One of those things is your heart. So if you've ever dealt with infants, you may have had situations where you are feeding one, you pick them up on your shoulder, and they go blah, and basically dump everything out. That happens because that esophageal sphincter is very, very pronounced in infants and can actually hold the milk down until you get them in the right position, and then it kind of regurgitates out. So that's one of the reasons that you put a baby on your shoulder and burp them instead of laying them down right after you feed them. So now we've moved from the esophagus through the gastroesophageal sphincter and into the stomach. And this large pouch is going to store food, but you're going to also be mechanically breaking it down because you have ridges known as ruga. You also will start producing some chemicals in here. You're producing the gastric acid. You'll be producing some enzymes we'll talk about in just a second. But you're also producing something known as an intrinsic factor. Intrinsic factor is a molecule that's essential for you to be able to absorb the B12 that you've eaten in your diet. So there are cases, for example, if you have a gastric bypass because you're trying to lose weight with these extreme methods, the bariatric surgeries type thing, you will actually have to take B12 supplements for the rest of your life because you've now lost that source of intrinsic factor. The stomach is made of 3 different layers of smooth muscle, and you'll see a lot of organs will be arranged that way. The heart is, the uterus is, and it's arranged that way for when you need to be able to produce quite an amount of force. So again, you can see the different layers here as cut away. On the inside, here you can actually see the little ridges that's known as ruga. So the cardia is going to be the part of the stomach right under the esophagus, referred to cardia because it sort of sits up under the heart. The fundus is this pouch over here, and the pouch will help store food and also grind it. It has this muscular activity that kind of moves the food about and grinds it along the ruga. The antrum is going to be the body of the stomach, and then the pylorus is going to be where you actually find a true anatomic sphincter, and that's where the stomach empties into the small intestine. So you do have a true sphincter at the pylorus. If you take a close look at the mucosal lining of the stomach, you will see it looks like this. And these are referred to as gastric pits. These gastric pits are lined with several different types of cells, and they have different jobs. First off, the gastric glands are going to be producing a very thick, slimy mucus. And that mucus is very important because it's going to prevent the stomach acid from digesting the stomach. So you also have a couple of different cell types here you should know. The parietal cells are the ones that will be producing intrinsic factor, and then they also produce the ever important hydrochloric acid. Chief cells produce a pre-enzyme known as pepsinogen. You have several other cell types here. I'll just mention the main ones. G cells produce something known as gastrin, and this gastrin hormone has a job of stimulating the motility. In fact, look at this word. It's not mobility, it's motility. So the contraction, the motion of the smooth muscle of the stomach, and it's going to also stimulate secretion of the enzymes and acid. So D cells kind of do the opposite here. They produce something called somatostatin, and this will quiet down stomach activity. And then there's also some cell types referred to as argentaphin cells, and these will be secreting histamine and serotonin. So I'm sure you've all experienced having a large meal and getting nice and sleepy, and that's because of this little thing right here, the serotonin. That's also a neurotransmitter that makes you nice and relaxed and sleepy. So the hydrochloric acid, again, is going to be breaking down food chemically. It's going to be stimulating release of bile and hormones that will be released in your small intestine. It's also going to be stimulating pancreatic secretions. As I mentioned earlier, it is a nonspecific defense system, and it's also going to take the pepsinogen that's been secreted by the chief cells, and it's going to turn it into pepsin. So just like acid, pepsin would self-digest the stomach. And because you have to make the pepsin in the stomach tissue, it's actually made in an inactivated form. Think of it as an enzyme with a little cap on it. And the little cap is not knocked off until it's secreted into the lumen of the stomach and mixed with the stomach acid. You'll see pancreatic juices, those will be containing enzymes that will do the same thing, trypsin and this sort of thing. They'll all be secreted as trypsinogen, and then it gets activated and turns into trypsin. So again, that mucus layer is very, very important to actually protect the stomach. It can be thinned by things like smoking, overusage of nonsteroidal anti-inflammatories, such as painkillers, such as aspirin. You can find Helicobacter pylori, the bacteria that will cause the gastric ulcerations. Again, alcohol abuse, cocaine abuse, and even autoimmune problems can wreak havoc with this mucosal layer and allow formation of gastritis. So as I mentioned earlier, pepsin is secreted here. It's secreted in the inactive form of pepsinogen, and it's cleaved when it is mixed with stomach acid. So this is a protease, and so it's going to have the job of digesting proteins. So now that we've eaten, we've swallowed our food, it's been mixed with saliva, now it's mixed with stomach acid, it's got all these different additives from the stomach that's been mixed in. We're going to refer to this substance as chyme. So this is a very soupy, very acidic product. And from this product, there's really not much absorption going on here. You may absorb some water, alcohol, and just interestingly enough, sometimes some aspirin might be absorbed. But this is one of the reasons they tell you when you should drink alcohol, you should do so on a full stomach to slow the absorption. How fast food moves through your GI tract is going to be dependent on your gender. It tends to move a little faster in men than it does with women. It's going to depend on exactly what you eat. And for the stomach itself, it's kind of interesting. You'll find a lot of regions and countries will have different cultural traditions after a large meal, such as dinner. And a lot of people have a glass of wine, some people have a cup of coffee. And both of these things will actually encourage your stomach to empty more quickly into your intestinal tract. So it makes sense that it's going to actually ease the feeling of being overly full, perhaps. So the other thing that will happen, the more you eat, if you overeat, then it's going to move out of the stomach a little bit faster. And then again, what you eat is going to have an effect on that. So carbohydrates will move the stomach more quickly, and then fats will stay the longest time with protein there in the middle, which is one of the reasons they tell you you should eat a well-balanced meal and have some of all three things there. If you eat nothing but carbs, you're going to be very hungry in a very short period of time. Control of the activity in the gastrointestinal tract is very complex. Again, we've already talked about it ranges from cell to cell next door all the way to control by the central nervous system. So when we look at what's happening in the stomach, there are actually three different phases. When you first start thinking about food, you have entered into the cephalic phase of gastric activity. Cephalic, of course, means brain or head. And so what's happening now, you're getting hungry, you're going to have blood flow that's going to increase to the stomach, and you're going to have secretion of hydrochloric acid and pepsin. You've got gastrin, that's the hormone gastrin that's going to be in control here. Your stomach's going to growl. Your mouth may water thinking about what you're going to eat. Then you start to actually put food in your mouth and swallow it, and now you've gone into the gastric phase. You're going to start stretching out the walls of the stomach as you get full. There are stretch receptors that will give you some feedback there. And food's going to stay here about 3 or 4 hours. So again, you've got all the gastric juices going on. You've got the pancreas that's kicking in and starting to secrete its enzymes. Now, just because this phase is referred to as the intestinal phase, we are still talking about what's happening in the stomach. So this is the intestinal phase of gastric activity, which means we're talking about the control of stomach action here. So the intestinal phase means that you're going to have secretion of hormones from the small intestine enteroendocrine cells. We'll have things like secretin, which is going to help stimulate some mucus. gastric inhibitory peptide, cholecystokinin. This last one is going to be stimulating secretion of bile and pancreatic juices. We'll talk about that a little bit more. So this is going to be giving feedback to the stomach, say, hey, don't empty quite so fast. The intestine can actually discover that there's too much undigested fats and carbs in the food that's coming down and say, hey, you need to spend some more time digesting this. Let's keep that pyloric sphincter closed a little bit longer. This slide is actually wrong. When I wrote this slide several years ago, vomiting was considered to be reverse peristalsis. Now they say that's not true. So what happens when you vomit is you actually have spasms of the diaphragm, and the increasing buildup of pressure in the abdominal cavity is basically going to push ingesta back up through the esophagus. So vomiting can happen because you've got some sort of food poisoning. Again, the solution to pollution is dilution. You've got gastric distension. I used to have a son that would eat very quickly, and then he would almost invariably throw up after dinner. So very rapid gastric distension would be a reason for vomiting. Distal obstruction, you might have something blocked in the small intestine. Eventually that's going to cause vomiting too. And if you have anything like bleeding ulcers, blood itself is very irritating. So long-term vomiting can cause problems because you're losing acid, so it's going to create alkalosis, and it's also going to mess with your potassium balances. So let's travel through the pyloric sphincter on down into the small intestine. So sometimes you'll see the term small bowel, same thing. This is where the vast majority of your nutrient absorption is going to happen. And you don't need to tattoo these numbers on your forehead here, but just to give you an example of the difference in the length of the small intestine in a living person versus a dead person, you'll see it's actually double. And again, as I mentioned earlier, that's due to that normal resting muscular tone that you'll see. The first section of the small intestine is the duodenum. Sometimes people refer to it as duodenum, but we say duodenum here at the school. And so the duodenum, the word itself actually means 12 inches, but it's only 10 inches, so the standing joke is it was named by a man. This section is going to be very tightly related to the pancreas position-wise. You'll actually see some regions that adhered to it, and that's important. We'll talk about why pretty soon. So you'll see here the duodenum is going to be what you see there in yellow. It's important to understand that the duodenum is going to be receiving the chyme from the stomach, which is very acidic, and so the first thing the small intestine needs to do is throw in a buffer. So it's going to be, again, it's going to have, just like the stomach, it's going to have a mucus protective layer, but it's going to start throwing in some alkaline mucus to try to buffer that acidity. And that alkaline mucus is going to come from the liver and also from the pancreas. The middle of the small intestine is the section referred to as a jejunum, which translates into the word empty. So a lot of the nutrient absorption is going to happen here. One of the things I need to talk about, and you have these throughout the entire small intestine, will be the villi and the microvilli. Those are finger-like projections. And just to give you a sense of scale, each square inch of mucosa is going to contain around 20,000 villi. So on top of those villi, so if we were to draw these looking like this, that would be the villi, and then you'd have millions of little microvilli on top of that. So each villus itself can be anywhere from about 0.5 to 1.6 millimeters in humans. So the purpose of that, again, is going to be increased surface area. So someone wrote, and I don't know how they prove this, but again, think about the small intestine of a deceased person being about 24 feet long. So kind of look at your tile on your floor and kind of picture the length of that. So it's not incredibly long when you think about it. And if you were to open it up, it might be maybe 2 inches wide because it's going to be kind of flaccid at this point. And again, not a huge amount of surface area. So without having villi and microvilli, what's going to happen when you eat, food's simply going to go straight down. Because you have these little structures, however, the very soupy food substance now is going to be going down between all these little finger-like projections and being very closely matched to areas of the mucosa. So again, you're going to have a whole lot more chance of food being absorbed than if it were to be a smooth tube. The other structure you'll see throughout the small intestine, something called plica circularis. So if this were to be a section of small intestine, you would actually have these permanent folds that will serve to further increase surface area. The terminal part of the small intestine is referred to as the ileum. Please note the spelling. If you remember from the bones, I-L-I-U-M is actually going to be the wings of your os coxa. So you also have plica circularis here. You'll have, again, some villi here. So the ileum, you're looking at this part right here. So to take a closer look at villus and microvilli, so what you're seeing right here is a diagram of the villi, or a villus will be singular, and it's got a capillary in the middle that is a lacteal. So we'll talk about this, but this is how you're going to have little globules of fat that will be absorbed, basically, because the fat molecules can't move through the mucosa like the carbohydrates and amino acids can. So again, on this side, you will actually see what they refer to as a brush border, and you can see because it kind of resembles a hairbrush. These are the microvilli, so this is what that would look like if you were to look at it under a strong enough of a microscope. Here's another close-up again, and it's not cut perfectly through the center, but it gives you a pretty good picture of the lacteal capillary. So again, the microvilli along the edges of the villi create that brush border, and there are some enzymes that are actually attached. So these are not free in the lumen of the intestine to be swept away. They actually are kind of bonded down. And an example of this would be something known as an enteropeptidase. Entero for intestinal, pepto for peptide, or piece of a protein, and ASE means it's an enzyme. So enteropeptidase is an example of what they refer to as brush border enzymes, but there are many more. The base of the villi is where you will find these little hidden pockets referred to as a crypt of lubricant. And these are going to be the location of goblet cells. Anytime you see goblet cells, you know they secrete mucus. We mentioned that in other chapters. You'll have Paneth cells, and these secrete a bactericidal substance. And then you also have what they refer to as duodenal cells, and these have the job of secreting an alkaline mucus. So again, this alkaline mucus is going to be helping buffer that acidic chyme that's coming through there. You will find the crypts of lubricant through the small intestine and the large intestine, and they are also the location of some cells of the immune system and stem cells that help replace the lining of the intestinal tract. Lining the small intestine, you'll find some cells referred to as enteroendocrine cells, and these will be cells that secrete their hormonal product into the lumen of the small intestine. And some big ones here are cholecystokinin, secretin, and GIP. Gastrin is another, and it's going to be released both in, you'll find it in the stomach and the small intestine, basically. But it's stimulated to be released when the stomach is going to be distended by a lot of food. So the function of gastrin is going to be stimulate hydrochloric acid production, and it's also going to stimulate gastric motility. It's going to close off the lower esophageal sphincter to keep that motility from pushing the ingested food back into the esophagus. The product of the enteroendocrine cells, gastric inhibitory peptide, GIP, is just like it sounds. It's a protein hormone, peptide hormone, that's going to tell the stomach not to empty so quickly. So when you have a lot of fatty acids and carbohydrates that are not totally digested, or if the duodenum is very full and distended, it's going to tell the stomach to decrease how quickly it's pushing things through the pylorus. The secretin is going to be released when the acidic chyme leaves the stomach and comes into the small intestine, and it's going to stimulate secretion of buffering type material, bicarbonate, from the pancreas and the liver. Cholecystokinin is also going to act on the pancreas and the liver, but in particular, we're going to be talking about the gallbladder. So cholecystokinin, if you break the word down, chole refers to bile, cyste refers to round, hollow structure, and then kinin refers to movement. So it's basically the biggest function is going to be able to stimulate gallbladder contraction. There are many more types of hormones, but the last two I'll mention here. Leptin is actually secreted by adipose tissue, by fat tissue, and this is going to decrease in appetite as ghrelin is going to increase appetite and make you hungry. So let's talk a little bit more about the accessory organs of the GI tract, in particular the liver, the pancreas, and the gallbladder. We'll talk about the pancreas first, and if you recall, we talked about its close association with the duodenum. And one of the things we'll be mentioning is how it empties out into the duodenum, and notice that it's very, very adjacent to the duct from the gallbladder. The word pancreas translates into all flesh simply because the secretions of the pancreas are capable of digesting a lot of meat. So you're going to have proteases, you're going to have lipases. So this is going to be the job of the exocrine pancreas. So we'll talk about the endocrine pancreas when we cover the hormonal section of the endocrine chapter. So the endocrine section is going to be secreting insulin and glucagon, but about 98 to 99% of the bulk of the pancreas actually has exocrine function, and that's going to be the job of secretion of pancreatic juices. So it is retroperitoneal, and just to complete the slide here, the islets, basically the clusters of cells that release the endocrine tissue, are contained in these little pockets referred to as pancreatic acini. Because we will cover the endocrine pancreas at a later time more in detail, the only thing you need to know now about that is that insulin is going to decrease blood glucose. So, for example, if you've eaten a meal, then the insulin is going to take the glucose that you absorbed and push it into the cells so it can be used. So it will lower blood glucose. So glucagon, on the other hand, will increase blood glucose because it's going to be released if you haven't eaten a meal for a while. You still have to have the glucose to run all your cells, in particular your brain, and so glucagon will bring glucose out of storage. It will break down the glycogen that you stored in the liver and the skeletal muscle, etc. So again, the exocrine pancreas is going to secrete the vast majority of the product here. If you look at this, up to about 1 to 1.5 quarts a day, your body puts a huge amount of fluid into your GI tract. So fortunately for us, we resorb most of that fluid in the large intestine. So again, you're going to be using a buffer here to raise the pH from the acidic chyme coming from the stomach. And just like we talked about with pepsinogen, a lot of these enzymes are going to be capped off in the inactive form until they're secreted into the lumen of the small intestine. That's going to prevent autodigestion or self-digestion of the pancreas. So pancreatitis is a really nasty, painful things to deal with. Amylase is going to be an enzyme that's going to help break down sugars, carbohydrates in other words. Lipase is going to break down fat. Nucleases, nucleic acid, and proteases will be your protein enzymes. So again, you've seen this picture before. If you take a close look here, you will see that the duct from the gallbladder and the pancreatic duct are going to be secreting basically at the same place. So you have a little bump referred to as a duodenal papilla, and it's going to be closed, open and closed, by a structure known as the sphincter of Oddi. The reason this is clinically significant is the formation of gallstones in the gallbladder, and they can move down this duct, and every now and then they can actually block the sphincter of Oddi. And what would happen, that would cause the pancreatic enzymes to go backwards into the pancreas, and you would get a really nasty acute necrotizing pancreatitis. So let's move on and talk about the liver and the gallbladder. The liver is a pretty unique and special organ, primarily because it can actually heal itself. So on the bad side is it's such a competent type of tissue that you can lose most of it before you realize there's a problem. But on the other hand, you can actually remove a lobe if you're going to do, for example, a living donation of your liver, and the liver will very quickly regenerate that missing lobe to the original size, shape, and then stop. So it's a pretty amazing thing. It can actually replicate itself faster than most cancers can actually grow. So you may say, well, why do people die of liver failure than things like cirrhosis and hepatitis? Well, the problem with that is, generally speaking, all the cells of the liver would be affected, so you don't have the healthy tissue that would be able to regrow itself. So your liver is going to take up most of the space of your abdominal cavity under your diaphragm on the right upper side. If the liver is swollen, you can usually palpate it under the ribs on the right side. Liver cells are referred to as hepatocytes. An immature liver cell would be a hepatoblast, just FYI. And so these have the job of examining the blood flow that's coming from the absorptive surfaces of the small intestine. So you'll see these blood vessels here are going to be very closely examined by the cells. You see there's a very close relationship between these cells and the blood flow. So remember about the hepatic portal circulation, and what a portal circulation is defined as capillaries that form a vein, and then they branch out into capillaries again. Normally, you would have a vein that will go to capillaries that will go into arteries. But in this case, you have the portal circulation, and so picture you've got the absorptive surfaces of the intestine, so the small intestine, and you're going to have all these capillaries that will be coming from that, and they will go into what's known as a portal vein. That portal vein will enter into the liver and break apart into the sinusoidal capillaries, and then they will reform or recoalesce and eventually go into the hepatic vein, which will be dumped into the inferior vena cava. Structurally, the liver is divided into individual lobes, and then each lobe is divided into lobules. These lobules are about 1 millimeter apiece, so you could see these with the naked eye, just not very well. And they're hexagonal in nature, and at each corner is referred to as a portal area. And at the portal area, you've got 3 structures: an artery, a vein, and a bile duct. So if you look at the diagram of this little lobule here, you'll see blood flowing in this direction. So imagine the small intestine down here. You're going to have, remember the portal system we talked about when we mentioned blood vessels. So blood will be flowing through here, and it's going to be exposed through all the little sinusoidal capillaries. Then they'll recoalesce here and end up going to the hepatic vein and into the vena cava, etc. So the sinusoids are actually, again, the term means sinusoidal capillary, and if you recall, those are going to be capillaries that have large gaps between the cells. Those gaps are so large that to decrease the danger of something getting into your bloodstream, you'll have a type of macrophage known as a Kupffer cell. So taking a closer look at this sinusoid, you've got your blood coming in from the portal vein, breaking out into the sinusoidal capillaries, and heading toward the vena cava, eventually via the hepatic vein. And you've got these little hepatocytes that are very closely monitoring the blood and removing what it wants to keep into the body and process. And again, it's going to be a lot of jobs that we'll talk about very shortly about what the liver is going to do. You can be putting things in and taking things out of this blood flow. And here it would be a Kupffer cell. So this would be your macrophage that's making sure nothing is coming through there that you want to prevent from getting into the main blood supply. So let's look at some of the functions of the liver. It is the most metabolically active tissue in your body. And one of the huge jobs, we've talked about this a couple of different chapters, it's going to be the site where the vast majority of your body blood proteins are going to be manufactured. So remember albumin, this is the most common plasma protein that you've got. It's this albumin that's going to allow us to have blood colloid osmotic pressure. So clotting factors are going to be made here. You're going to have ammonia detoxified and converted into urea so it can be ready for excretion. You're going to also have drugs and alcohol that's going to be detoxified here. So you'll find that there are certain types of anesthetics and antibiotics that are going to be processed here. If you have liver failure, they're going to want to use anesthetic or an antibiotic that's going to be processed and excreted by the kidney and vice versa. So the enzyme alcohol dehydrogenase is going to be the enzyme that's going to obviously process out alcohol. Now, I always warn people, you go to the physician and they'll ask you about your habits, do you smoke, do you drink, etc. I always say never lie to these people. One of the reasons is, especially if you're having a pre-op appointment for a surgery, if you are a moderate to heavy drinker, they know that you're going to have a large amount of alcohol dehydrogenase in your liver. And so they know to go ahead and plan to use perhaps a little bit heavier of a dosage of anesthesia. So, in other words, if you don't drink, then you don't have as much of that enzyme present, and you could get by with a lighter dose. So, waking up on the surgical table would not be my idea of fun. So some of these we mentioned on the last slide. A few of these are going to be fresh here. You actually store a lot of blood in your liver. The liver is extremely vascular. You can hemorrhage very badly from a lacerated liver. The liver is going to be where a lot of your immune activity is going to take place because of the concentration of the blood flow here. I've already mentioned to you the plasma proteins, a tremendous amount of metabolism going on here. Glycogen, the glucose, and your lipids for your fats and your amino acids for your proteins. A lot of metabolism going on here. And it's going to be removing things from your blood flow that you don't want to keep, and that's going to be excreted into your bile system. You have a lot of vitamins and minerals that will be stored here. One thing to point out, and a very common one here, would be stuff like iron, copper will all be stored here. And this is one of the reasons that if you are taking an excessive amount of iron, you can actually cause liver failure. The vitamins in particular that are stored here are the fat-soluble vitamins. So those are vitamins A, D, E, and K. So also, you're going to have synthesis of the bile salts, and these will be excreted again through the bile system. Bile is a form of a mechanical digestion. You would think it's chemical, but it's not. So what it's going to do is it's going to emulsify or break apart large droplets of fat. So again, when you've got things like glucose, you've got amino acids, those can simply diffuse across the mucosal membrane, but these large lipids cannot. So in order to make these large droplets smaller, so things like pancreatic lipase can break it down even further for absorption, the bile acids will actually break down these large molecules. So the substance bile is made in the liver, and is going to be sent out through the little tiny structures known as the bile caniculi, meaning tiny canal. And these caniculi will form together to create the hepatic duct. So the common hepatic duct then leaves the liver, and you'll have bile that can go in two different directions. It can go straight down through the common bile duct into the small intestine, or it can go through the cystic duct into the gallbladder for storage. The gallbladder is considered a vestigial organ, which means that evolution probably could have gotten rid of this a long time ago, but it didn't. So it's one of those things that does not always function very well. So you can end up with the bile being concentrated too hard, and you can result in bile stones. And here's a couple of different examples here. Obviously, the chemistry is going to be a little bit different. But the condition of having gallstones or bile stones is referred to as cholelithiasis. Cola, again, for gall, and then litho refers to stone. So the removal of these is not very difficult at all. It's typically done on an outpatient status. I personally had an uncle that was not properly diagnosed for about a month. He was in another state, and my mom would tell me that he had been itching all over, and he went to his local physician, who was not known for his diagnostic talents at best, and he told my uncle that he had hives. And so he treated them, gave him probably some prednisone or something like that, and sent him home. Next thing, he goes back a couple of weeks later, he's still miserable, and he's told that he's got shingles. Waits a few more weeks, and my mom happened to comment on the phone to me one day that he was very yellow, and that his stool was a odd white clay-colored stool. That in itself is diagnostic for blockage of the bile system, because the bile is what will make feces a characteristic brown color. So eventually they diagnosed this. The man was miserable. He lost a ton of weight. When I did visit down there, he was almost unrecognizable, and he was a very characteristic jaundiced yellow color from all the backup of bile into his bloodstream. Moving down into the large intestine, so again, just like the small bowel, sometimes people say large bowel here, you'll see it's much shorter and it's much wider. So some important structures that you need to know about, first off, would be something called the Taenia coli. The Taenia coli is a smooth muscle band that runs down the length of the large intestine, and I always think of it as like a stitch that would create pleats, and these pleats or pockets are known as haustra. So those are the haustral pockets. And what will happen is a contraction of the smooth muscle lining of the large intestine, and it will sort of squeeze the contents. So the main, I won't say main, but a very important function here of the large intestine is to absorb water. Think of it as being a sponge that's going to soak fluid out of the contents. So by the end of this process, you'll end up with a harder, drier, more compact feces. So you do have some bacteria that live here. This is your normal flora. And while we can't process and digest things like cellulose, these bacteria can. And they will actually produce some bacteria that are important for us, some B vitamins, for example, vitamin K, and we will absorb those. The structures you should be familiar with. First off, the very first section that you go into from the ileum is the cecum. So it's just kind of a little pouch section, and there is a valve known as the ileocecal valve that is going to be preventing contents and bacteria flowing backwards into the small intestine. So hanging off the cecum, you'll see this tiny little finger-like appendage. It's known as the appendix. So again, that's thought to be primarily vestigial, but they are discovering now that it is a location of a lot of lymphocytes, so they think we might have some immune function going on here. And also, it's been theorized that it's serving as a little storehouse for some of the good, normal, healthy bacterial flora for a large intestine. So the colon is going to be the bulk of the structure here. So we'll talk about on the next slide the different portions of that. But you're going to move there from the colon into the rectal canal and pass through the external sphincters, the internal sphincter and the external anal sphincters. So looking at this diagram, again, you're going to be going from the small intestine. You're going to be going stomach, duodenum, jejunum, ileum, passing through the ileocecal valve, which is basically just some flaps of mucosa that keep things from flowing backwards. You're going to be going into the cecum, which is a little large bind-ended pouch here, and here you'll see the appendix hanging off the end. So from there you're going to be moving up through the ascending colon, across through the transverse colon, down through the descending colon, you'll see this sort of kink here that is going to be moving into what's known as the sigmoid colon, S-shaped in other words, and then you move down into the rectum and then finally through the anus. One thing to note here, when they're doing a colonoscopy, obviously they're going in from the anus, so they're much better able to visualize this part of the intestine, and sadly a lot of really nasty colon cancers will be concentrated on that side. So again, looking at the overall functions here, and you'll see some variation in textbooks. For my purposes, we're going to go with what's on my slides. And so again, water reabsorption. So you're putting a tremendous amount of fluid into your GI tract, and you're going to have to resorb that or you would end up chronically dehydrated. The bile salts, some of those will be reabsorbed. You're going to have the bacteria here that's going to be producing vitamin K and also your B vitamins, and so those will be absorbed. On this slide, I see this should be secretion of organic waste. So I mentioned earlier the sphincters. At the end of the rectal canal, you're moving into the anus. There is an internal sphincter and an external sphincter. Internal sphincter is smooth muscle and involuntary, and the external sphincter is made out of skeletal muscle, which therefore should have voluntary control. So a couple of terms: tenesmus is when you cannot relax the sphincters, and then incontinence would be the opposites, when you can't control the sphincters. So here is a summary of the differences between the small intestine and large intestine. So the small intestine is longer. It's got much more thick walls. It's going to have villi. You're going to have enzymes produced here. And the types of motility will be peristalsis and segmentation. And then the large intestine is going to have a much thinner wall. You have no villi here. And the only thing that's going to be produced here, as far as by the actual structure itself, will be a lot of mucus. And the motility here is referred to as haustral turning. So you'll have contractions of those smooth muscle bands that I referred to as Taenia coli, and that will kind of squeeze up these pouches, allowing you to better absorb the water. So the forward motility here is referred to as a mass movement. I'm trying to finish this lecture before my dogs get totally wound up. I keep having to stop because I keep playing with chew toys. My old lectures, I had an old storage dog, and this time I've got young playful dogs, so I apologize for anything you're hearing in the background here. So I did want to point out, again, I mentioned earlier about fecal color, and normally it's going to be brown. I actually had a student ask me one day why was poop brown, and I said, well, here it is. When you break down blood cells, and again, your body's breaking down millions of blood cells per second because they age out about 120 days, so the spleen is taking them out of circulation and breaking them down. The hemoglobin that's released is going to be processed by the liver into biliverdin and into a product known as bilirubin. So if you break down too many red blood cells or your liver is not working, this bilirubin will back up into the bloodstream, and that is going to cause you to be jaundiced. So bilirubin is going to be processed into urobilinogen and stercobilinogen, and urobilinin is going to be released into the urine, will make urine yellow, and the stercobilins will be released into the gallbladder and into the intestinal tract, and going to be basically making poop brown. So for testing purposes, the only things that I would want you to know here would be the processing of hemoglobin into bilirubin. A couple more terms for you here that you should be familiar with. Diarrhea, I'm sure you're familiar with. It's simply production of feces as too liquid. That can actually be the result of things moving too quickly through your intestinal tract. Again, solution to pollution is dilution, so your body might be purposely trying to expel something. Ileus is when your motility is decreased or absent, and it can be deadly. It can be caused by infections. It can be caused by certain medications. You may have seen TV commercials advertising medications meant to relieve the constipation caused by use of opioids. So we have pain. We take medications to relieve the pain. And again, we have a huge opioid issue in this country. We take more opioids than any other country by far in the world. And then we have to take medications to relieve the ileus that's being caused by the opioids. So the problem with ileus, number one, you can result with, at minimum, again, constipation because the gut's not moving, so your intestine, the large intestine, is absorbing more and more water out of the contents, and so the contents are getting harder and harder and drier. But most dangerous part of this is that because the ileus is sitting there, because of the contents that just sit there, you can absorb toxins that are being produced by these bacteria. You can end up with a nasty overgrowth of potentially dangerous or deadly bacteria. So if you've ever had surgery in the hospital, one of the things you'll notice them doing as you go into recovery is they'll use a stethoscope to auscultate your abdomen and all the quadrants, listening for normal gut sounds. Well, we're going to end this lecture on a crappy note. I don't expect you to know these for testing purposes, but one of the things that you'll work with if you work in the office of a gastroenterologist is the Bristol stool form scale. And basically normal should be right around here. So here you see the results of most often decreased motility, and here is often caused by increased motility. I will have to say though, just because somebody has ileus or severe constipation doesn't mean that you can't have some liquid that leaks around there. So you can have, and you'll see this especially in elderly patients, you can have an intestinal blockage, but you still got diarrhea because the liquid feces is coming out around the blockage. Like everything else in the body, if you simply pay attention, you can actually pick up a lot of information to the detail here. So, as I mentioned earlier, if you have a bowel obstruction, you can have what's referred to as an acolic stool. It's often referred to as a clay-colored stool. A green stool can be indicative of simply diarrhea because things are moving so quickly through the intestinal tract that bile is not being broken down. Steatorrhea would be a yellow or kind of greasy stool, and that's often indicative of a malabsorptive type disorder. Two types that you'll see might indicate blood in the stool. So the most worrisome is a black tarry stool referred to as melena, and this is indicative of upper GI bleeding. The blood has been digested, which is why it appears black. So a bright red stool, known as hematochezia, might be something as simple as hemorrhoids, or it might be more worrisome as talking about colon cancer. So, okay, I think we have digested this chapter enough, and we will move on to the next one.